So in my talk, I'll be presenting about these different dimensions I presented, the clinical syndrome, the age of onset, and APOE, and how they're related to brain pathology and disease course in AD. That being said, I'm going to start by showing data from this neurology paper that came out. And here we looked at 3 different phenotypes of Alzheimer's disease patients with amnestic AD, posterior cortical atrophy, and logopenic variant PPA. And these maps show you the average amyloid burden measured with PET. PIB is the first tracer that was developed and published in 2004 already. And what you can see is really that amyloid in these 3 phenotypes, amyloid is really all over the brain. It's very widespread, and it doesn't really seem to distinguish the 3 variants. The pattern is really different with tau PET, and this is using flow tau CPR, which is also this tracer that you might have read about as T807 in the beginning, and then AV1451. And this tracer binds to neuritic tau, like tau in tau tangles and neuritic plaques. And here we have very different, distinct patterns, and that you can see are really strikingly different when you assess them statistically. With the posterior cortical atrophy variant having a lot of occipital binding, and the logopenic variant with major language deficit having a very asymmetric pattern with left predominant temporoparietal binding. And when we looked at structural MRI using voxel-based morphometry, nothing crazy about the method here, we do see that the pattern of tau really seems to mirror the pattern of structural MRI. And that actually leads me to another study that we did that tried to investigate a little more the relationship between tau and structural MRI. And we were lucky enough to have some patients who came back to us with for a second MRI around like 1.5 years after the first session of imaging. And we measured brain atrophy over time with this technique that at least one of you should be familiar with in this panel, to measure longitudinal changes in brain structure. What we saw is here on these plots, the x-axis shows the baseline abnormalities measured here on these scans. So baseline amyloid, baseline tau, baseline cortical thickness at baseline in the entire cortex, and how it related to the y-axis being the longitudinal rate of atrophy. What was really clear here is that baseline tau was the best predictor of future atrophy. Like these patients were actually randomly sampled, and how the baseline tau really forecasts where atrophy is going to be in this patient. The age of onset and the age at which we scanned patient had nothing to do with how much amyloid they had in their brain, but it was really strongly related to tau, and in this very strong negative pattern. And this sample is the same I showed you before. It includes these atypical variants of PCA and LVPPA, and we actually saw that this relationship with age existed within each syndrome. It's not driven by these atypical syndromes. It is really, all the lines are really impressively parallel, and we do see that younger patients have more tau regardless of their syndrome. When we dig a little more into the spatial information in here, we actually saw that this is a map of the correlation between age and tau PET signal, and we see that this negative relationship is really found all across the brain, but mainly in the frontal and parietal area. And if anything, there's one region that doesn't show this association. That's really the temporal cortex. So the temporal burden of tau seems to be pretty invariant of age of onset. This is a finding that's been shown by other groups in the last few years. What I really want to emphasize is that this is cross-sectional data. It doesn't mean at all, some people get really confused with this. It doesn't mean that tau decreases with time. It means that younger patients have more tau. And there's this study from the Mayo Clinic that shows over time, the patients in blue, younger patients have more tau at baseline and they increase faster. So this is just a pattern that we see in everything we're looking at. The early onset form of the disease are more aggressive, probably because of this higher tau here. One thing that I really learned and reflected on in the last year is how, as neuroimagers and biomarker researchers, we really rely a lot on pathology as a gold standard for what we develop. And I'm not sure that the measures of neuropathology are always the good one to use as gold standard, because a lot of these measures are not quantitative by nature. And here, all these patients, like the different 4 rows, I don't know if you can see the details, but the 4 rows are 4 patients that were all diagnosed with Alzheimer's disease with BRAC6, so meaning they have tangles all over the brain, they have tau tangles in their motor cortex, but still there's a huge variability in how much they have, because the BRAC staging or the tau staging phasing for amyloid is just topographical. You get assigned to a certain stage or phase based on whether they find amyloid or tau in given regions, but it has nothing to do with how much there is. And I think that we can expect that our measures in vivo might be reflective of the quantity of the pathology burden more than just where it is. And so when we looked at this, when we use this quantitative measure, we look here again at age of at symptom onset on the x-axis and the tau tangle and the y-axis. And for all these cortical regions, we see this very steep negative relationship, exactly like we saw with PET. And when we probe the hippocampus, we actually don't see this relationship. It's a very weak relationship. So the finding from the brain bank was really interesting because it really confirmed what we see with PET, that older age of onset is associated with less tau in the cortex, but not in the medial temporal lobe. So it's not just that there's less tau overall, it's the pattern, the distribution is a little different between early and late onset. Like I mentioned before, early onset Alzheimer's disease has been shown before to be a more aggressive disease than later onset. There's a paper showing there's a faster clinical decline or higher atrophy rate. And this is the data from the brain bank data set, all the patients that were path-proven AD. And you can see here their decline in MMSE over time. If you fit a model into this data and you try to predict a 5-year cognitive decline in these patients at age 58, in 5-year patients lose 20 points on the MMSE. At age 74, they only lose basically almost half of it. So the cognitive decline is really different here. Talking about this, this more aggressive pattern early onset, one thing that we looked at, going back to the study about longitudinal atrophy, what we did see is that our younger patients tended to have higher atrophy rates, so more aggressive disease. And so we know that younger patients have more tau, they have more like steeper rates of atrophy. And we ran this mediation analysis showing that actually the fact that young onset patients have more tau could explain why they have more aggressive atrophy over time. So there's all of this seems to be going together. So the last data I want to show you regards APOE4. As I mentioned, it's the main risk factor for AD. And in our sample, in the neuroimaging sample, we actually saw this extremely focal effect of APOE4 on the medial temporal lobe. And if you look a little closer, it's really in these typical entorhinal hippocampal regions, where we see that APOE4 carriers have more tau PET signal than non-carriers. If you see here, this is true when you control for a lot of variables, including clinical phenotype, including amyloid PET. So this would be an effect of APOE4 that is affecting tau pathology independently from amyloid. And this was so focal, and even when you loosen the statistical threshold, it was still very restricted to the medial temporal lobe. I was a little doubtful of this at first. And then there's this paper that came out. This is a paper from the group in Montreal. They show in 2 cohorts in ADNI and in their own data set the same finding. I think these are not only 2 different cohorts, these are 2 different tau tracers. And then there's this paper from the MGH Boston group showing effect of age amyloid on tau, but also actually when you control for age and amyloid, you can still see an effect of APOE4 very focally on this medial temporal lobe. All right, so just to summarize a little bit, we saw across both neuroimaging and postmortem data sets that the clinical variability was really associated with tau way more than with amyloid pathology differences. What is really intriguing to us at this point is trying to figure out why these patterns of tau would differ. And I'm thinking specifically about the different phenotypes. We don't know if it might be related to some genetic differences that explain differential regional vulnerability to tau. There's also very interesting literature showing a higher prevalence of early developmental differences in patients who would end up developing these atypical variants of Alzheimer's disease. And there's data from our center and others across different centers, actually, showing that patients who develop this language predominant phenotype of Alzheimer's disease tend to have a higher prevalence of dyslexia in younger age. And similarly, there might be some early life developmental differences in mathematical and visual-spatial abilities in patients who will end up developing PCA, the visual-spatial predominant form. So the idea is that maybe these early life differences would, like, basically the tau pathology doesn't happen in a vacuum, and it happens on a brain that is pre-wired or that has pre-existing differences. That might explain why tau pathology is going to happen in these regions more than others. The other thing is that you're always told that older age and APOE4 are the main risk factor for Alzheimer's disease. I think they're not just risk factors, they also modify the way the disease is presenting. And, age is associated with less, like older age is associated with less tau in the cortex. APOE4 is associated with more tau in the medial temporal lobe. So basically this like ratio of how much pathology is in the medial temporal lobe compared to the cortex is higher in these two situations. And so basically it tells you that these two factors are associated with this quote unquote typical presentation of Alzheimer's disease that is more medial temporal predominant, more amnestic. And what's interesting is that these effects seems to be really directly on tau and not through not going through an amyloid pathway. To summarize the age of onset finding, we do see that there's this reversed relationship with younger patients having more tau but less co-pathologies. The idea of why patients with late onset don't have as much tau might have to do with how many pathologies they have in their brain, and maybe the fact that they have all the things going on lowers the threshold for tau to be clinically relevant. We also don't know, maybe the tau pathology that happens in early life or in late life is not exactly the same from the biochemical perspective. And maybe it's not the pathology that's different. Maybe it's because the brain itself, a pathology that happens to a brain that's 40 years old versus a brain that 8 years old happens in a different context. So maybe it's the interaction between the pathology and the premorbid brain that explains these differences. The clinical relevance of the Alzheimer's neuropathology is hard to estimate. I think the problem in the current stage of the field is that we have biomarkers that work pretty well, although there are problems regarding cost and different things. But we can detect amyloid and tau. The problem is that we cannot really detect so much of the other things. So we might be biased towards giving too much importance to amyloid and tau, because when we see amyloid and tau in the patient, we tend to attribute symptoms to these pathologies, when actually it might be related, some of it might be related to the other things going on. But we do think that we have to think about this when we design clinical trials to lower amyloid and tau pathology in the brain, because how much impact can we expect based on the fact that other pathologies are happening here?
Yeah, so I thought that was brilliant. Thank you very much. You touched on this briefly in your last slide about the implications of your work on different treatments. So I wonder if you could expand on that a little bit more.
Yeah, this is really, really a great point. And this is something we try to think about a lot. I don't have all the answers, but I do want to emphasize that this specific question of age of onset is something that hasn't really been looked at in details in trials. I do think that it should probably be a stratifying variable, because we've seen too many differences in between early, like young and late onset patients. And again, I want to just emphasize that this these plots I'm showing with PET imaging, where younger patients have way more tau than older, they're clinically, in terms of MMSE or CGR, like all the global scales, the patients are similar. So if you just, and which is really pretty striking. Usually when we look at scans, we sometimes like play this game where we're trying to identify, like, to guess the patient's age based on just the scan, because it's really visually striking. I think regarding trials, we really need to consider this. I think it's a very important case you're making about maybe actually, once a patient has too much tau, what is the point in lowering amyloid? It is like, I think the new trials are really acquiring a lot of data to try to understand if there are subgroups of patients their treatments are effective. My guess is that, based on what we see with these patients who have so much tau all over the brain, and we know that this tau is probably forecasting a very bad outcome for them, within a year. I don't think there is much point in lowering amyloid in these patients. It's like amyloid is past history probably for these patients. But maybe for older patients who don't have so much tau yet, we can maybe, if this whole cascade is true, maybe getting rid of amyloid in these older patients might, work more, because amyloid hasn't triggered all the downstream tau yet. But the problem is that, like we showed, the older patients also have a lot of things in the brain that is unrelated to Alzheimer's disease. Right. So the proportion, it's hard, we can't really do that, but the proportion of their symptoms or their severity that can be attributed to Alzheimer's pathology as amyloid and tau might not be really big. So, I don't know how much clinical efficacy we can expect from a treatment that's targeting one pathway in these patients who seem to have a lot.
And I have two questions, actually. The first one, you talked about higher tau in the cortex in younger patients and also females. And I would like to ask, and sorry if you mentioned and I missed it, if there was a specific cortical region that either for females or for young patients, that saw a higher difference. And the second one is if you think PET tau could be used like in clinical practice in the future, because you did mention differences in, spatial differences that could differentiate AD subtypes, in tau accumulation. And I also saw Susan Landau, that made me think of the meta ROIs for FDG PET. So yeah, if something like similar, looking at regions of interest would be something, that would be used in clinical practice. Sorry, that was long.
Yeah, no, that's great. These are all really great questions. I think, the age, the effect of age of onset, I think we really see it. It's pretty widespread, but we definitely see it mainly in parietal and frontal cortices. The temporal lobe doesn't show that relationship with age. I showed the hippocampus, but it's also like most of the temporal lobe doesn't show this relationship, which is kind of good, because I think a lot of papers, you're talking about Susan's meta ROI for FDG. For tau PET, we tend to use a lot of this thing that a lot of people call meta ROI as well. For tau PET, that is mainly grabbing data from the temporal cortex, which is good because then it's kind of invariant of the syndrome and the age of onset. And it's kind of like the common denominator for tau pathology. And, even our atypical variants, even a patient with posterior cortical atrophy with a lot of occipital tau, they also have temporal tau. So we're not missing them out with taking this temporal cortex. The problem is that I think there's two different things. Is that if we're trying to detect the presence of tau and Alzheimer's pathology at large, it's sufficient. If you're trying to say positive or negative, it's going to work. The problem is that then, it goes back to one of the concepts that I introduced early on of like tracking disease progression in patients. And it's going to be hard if you're measuring brain atrophy or if you're measuring tau. It's going to be hard to think of one region, one, like in that simple way, one region that would be good to capture disease progression in everyone. Because in the patient with posterior cortical atrophy, you're going to find differences in tau, but in the temporal cortex, and you might increase a little bit over time, but this is not the main regions that's going to increase. So if you're just measuring temporal cortex for everyone, you're kind of going to underestimate how much these patients progress, because they're progressing more in a different region. So I think this is definitely going to be an issue. And going back to the sex difference, we didn't really see a pattern. It was kind of all over the place, a little bit as if the female, the tau pathology in females was like, one step ahead, like a little more progressed overall, as far as we've seen. But in terms of clinical use, I don't think tau PET is going to be the thing that everyone is going to get. It's not consumable for many reasons, practical, financial, many things. I do think that it's very important in trials right now, because we need to both be able to stratify patients, and also see the key thing, and even in, well, if you're targeting tau pathology, of course you want to image tau pathology to see if you're engaging the target, right? Just like all the anti-amyloid treatments. We don't know if they really work clinically, but we know they remove amyloid. So at least they're not failing because they're not engaging their target. For tau, I think it's going to be interesting. If you're targeting tau, you need to make sure tau is moving, changing. But actually, if you're targeting amyloid, like, you really want to know if it's going to have an impact on tau. So I think for trial, it's going to be super important. In clinical practice, probably not. Maybe in some very specific cases.
I wanted to follow up on quickly on the age of onset relationship that you were talking about, and you said that there's an absence of the correlation in the temporal lobe, medial temporal lobe, perhaps surprisingly or perhaps not, as you indicated. But I was wondering if one of the issues there is that effectively in your data set, that's already reached some kind of ceiling.
Yeah, that's a very great point. I totally agree with what you said. The way we're talking about patterns here might have to do more with like the relative distribution of pathology overall than the absolute, because I agree that there's no like, it might seem that maybe the tau, the temporal tau burden is kind of plateauing somehow. The one question though, like, that it doesn't solve is, like, if there's as much tau in early and late onset, why, for the same given amount of tau pathology in the temporal lobe, why do some have additional in the cortex and some don't? And so I think it doesn't solve, like, because apparently for some patients, they didn't wait until they saturated the temporal lobe to go to the cortex. So why is this? And there might be something that has to do with either, regional vulnerability to accumulate tau, or regional or vulnerabilities to spreading tau outside earlier on. As soon as there's some tau, maybe it spreads somewhere else, whereas in some other patients, it kind of accumulates locally before moving elsewhere. And I think this might be the difference between the early and the late onset.
Thank you again, Renaud, for for sharing with us a very enlightening set of studies. That's great to have you present to us today, and thank you very much for your time this morning.